Good evening, all the aspirants. Here we have the speaker, Dr. Nikhilesh Jain, and the topic for today is Renal. And Dr. Nikhilesh Jain is the Director and Operational Head Depth of Critical Care Services at CHL Hospital Indore. So you may continue. Thank you.
Relatively simple thing to answer, dose of effluent volume of CRRT in patients of AKI in critical care. Everybody is answering D. Any particular reason? What we suggest is ideal actually, without assuming there are going to be no breaks or anything of any sort in an ideal world situation. Pika immediately corrected. Okay, so Christina got it wrong, but Pika corrected it. Lean has got it correct. So this is indeed the right answer. The dose of effluent volume of CRRT in patients of AKI in critically ill patient, what is recommended is 20 to 25 mils per kg per hour. This is standardized, it is given everywhere in the literature. So there's a no-brainer, you have to know this. The dose of effluent volume of CRRT in patients of AKI in critically ill is 20 to 25 mils per kg per hour. So which of the following values indicate pre-renal acute renal failure? Answers. This is again simple. This everyone has got it correct. And if I were to discuss fractional excretion of urea, then what would have been the variable that would have been discussed? We would have discussed something about diuretics, Last time we did it in one of the sessions. Okay. So here you have a patient of COPD who presented in this ICU with a PCO2 of 100, PO2 of 50, pH of 7.23 and bicarb of 36. So you can very well appreciate that there's a respiratory acidosis for which there's a compensatory metabolic alkalosis that is happening there. Now the patient was placed on NIV and was also nebulized with high dose of salbutamol. So the following reports came from the lab. Sodium of 140, potassium of more than 10, chloride of 111, calcium of 0.3, magnesium of 0.2, alkaline phosphatase 14, and the resident was confused. He called up the consultant and the consultant gave him the diagnosis. So what do you think has happened here? Oh, the pin drop silence. So difficult. Okay. For example, what else? Okay, I'll put it again. Everybody's sure it's D, huh? Any other answers? I'll go back to the answer slide now. Yeah. Because this is the second time you changed. Okay, now Salah has also come around. So the answer is indeed potassium EDTA contamination here. This seems simple. Which one of the following is not a cause of chloride responsive metabolic alkalosis? Correct. Venus has got it correct. So, true. So the answer is E, because the urine chloride levels in primary aldosteronism are more than 20 milliequivalent per liter, unless there is an actual chloride retention happening at some other physiological level. All the other causes, if you look at it carefully, and I'll go back to them, they have all got chloride levels which are less than. Now, which one of the following is most likely to cause dialysis-induced hypertension? The option is most appropriate. Remember that. The option is most appropriate. Okay, Salah has answered C. No other takers. So the answer is actually here is a low calcium dialyzer. The answer is D. And 25% of interdiabetic hypotension happens with a rapid urea removal. It also depends on the choice of dialyzer and the dialysate composition. So if going back to the question, you get options like these, low calcium dialysate is the more appropriate thing. High sodium, of course, will never do. So high sodium is the most unlikely. Among the other three options, the most appropriate option would be a low calcium dialysis. So this is a question 6. In patient of acute kidney injury, these are the options. This can be attempted as both. You can pick and try to choose a single option as well, and you can pick and try to choose other options as well. You can make it into a K-type question as well. Neil, you have to put it in the options like Pika has done, something of that sort. So the answers are F. Wait a minute. There were two that we got actually, F triple TF and FFTTF. So the answer is FFTTF. I think Leal got it right. So that is what is correct here. Going back to the options, uh, serum urea and creatinine are not sensitive markers. So this is F clearly. It is not typical. Finely granular the cast is not considered typical of ATM. So that is one thing. And pre-renal ARF fractional excretion of sodium is typically, we covered this question before. And anemia is a typical finding. All those things, I think Lead only got it right. FFTTF. Lead only got it. So question number 7. 64-year-old male, history of cirrhosis, secondary to Hep C, is being evaluated for abdominal pain. This patient reports worsening generalized abdominal pain and fever for the past 4 days. He denies hematemesis of melena. BP is 110 by 60 mm of mercury. Heart rate is 95 beats per minute. His physical examination is significant for icterus, ascites, and generalized abdominal tenderness. Lab analysis is notable for white cell count of 18,000, creatinine of 1.1, blood urea nitrogen of 36, and total bilirubin of more than 4.3 milligram per deciliter. The patient received broad spectrum antibiotics, and which of the following drugs is most appropriate to administer to reduce risk of renal failure in this patient? I'll go to the options. You've gone to the question. Question is a large one. If you say yes in the chat box, then only I'll move forward to the options. First, yes has come. I will move forward. These are the answers. So which option? This is a single option now. Which option do you think is most appropriate or most correct among all four? All are rating A. He has denied any history of hematemesis. Think about it. No hematemesis here. Huh? Okay. So the answer here is B actually. Albumin 1.5 gram per kg now and 1 gram per kg on day 3. How we go about it is albumin appears to be most effective in patients with serum creatinine more than 1 milligram per deciliter and total bilirubin of more than 4 milligram per deciliter. But its effect is unclear in those patients who have lower creatinine and bilirubin levels. If you look at the European Association for the Study of Liver guidelines, they talk about starting albumin infusion in all patients with spontaneous bacterial peritonitis. The recommended dose here is 1.5 gram per kg at the time of diagnosis and 1 gram per kg body weight on day 3. Terlipressin, midodrine, octreotide, they are all are used as treatment options for hepatorenal syndrome or probably with an ongoing variceal GI. So next question. 26-year-old, previously healthy, G1 gravida 1 para 0 female at 36 weeks gestational age, comes to ED because of polyuria, nocturia, and polydipsia. Her pulse is 78 beats per minute, BP is 102 by 63, and weight is 53 kg. Physical examination is normal except for decreased skin turgor and dry mucous membranes. Lab data reveals low urine osmolarity to the tune of 89 milliosmoles per kg, serum osmolality of 308 milliosmoles per kg, serum sodium of 144, potassium of 4.1, chloride of 109 milliequivalent per liter, blood urea nitrogen of 10 milligram per deciliter, creatinine of 0.7 milligram per deciliter, glucose of 110 milligram per deciliter, and HbA1c of 5.3%. Serum ADH is zero point 0.5 picogram per ml. MRI of her brain demonstrates no acute findings. So which of the following statements best explains the symptoms? Have you all gone through this? I can push on to the options part. Sana has mentioned for the past question that Turley can be used for HRS and SBP. The point is not whether it can be used. The problem here is that you have to come to the most appropriate option here. So the most appropriate option in that setting would have been albumin. That was a single answer question, right? If everyone has gone through this, I can push on to the answers. Yes. So, so these are my options. What all could have happened? She may be having a kidney disease which is affecting renal sensitivity to ADH. She may have an ischemic insult leading to decreased release of ADH. There may be placental trophoblast producing excessive vasopressinase, and there can be an autoimmune destruction of the pituitary. So, what do you think is the answer? Any wild guesses? Any other answers? This is the third option. Now you're left with only one option. I've got B, I've got D, I've got A. So, unlikely as it may seem, all of you are actually wrong. The answer is C, and it usually develops at the end of second or third trimester of pregnancy. It will resolve spontaneously 4 to 6 weeks after the delivery. The pathophysiology, it's gestational diabetes insipidus. It is different from both central and nephrogenic DI, and rather than a deficiency in ADH secretion or decreased receptor sensitivity, it involves excessive vasopressinase activity. It is something new, so I've included it.